Hi, today we'll discuss about difficult embryo transfers. What is difficult embryo transfer, or what exactly do we mean by calling an embryo transfer as difficult? See, basically the final culminating point of doing an IVF is embryo transfer. So till then the clinician is involved in making the proper oocytes, and then the lab is involved in making proper embryos. And if we go wrong in placing the embryos back into the uterus, then there is a very high chance that we may not reach a pregnancy. So embryo transfer is the most crucial and critical phase of an IVF cycle. However, all parts of IVF are important, but yes, once all the hard work is done and then we have good embryos in hand, we can't go wrong in placing them. We call it as a difficult embryo transfer when certain parameters go wrong. For example, if there is a need to hold the cervix while putting the embryos inside, if the clinician finds it difficult to enter into the uterine cavity, if there is blood in either the outer catheter or the inner catheter, and if visibility is difficult during the ultrasound, and of course if the procedure takes too long and the doctor is finding it difficult to negotiate through the internal loss. Now these parameters lead to what is called as difficult embryo transfer. Now, what are the repercussions of difficult embryo transfer? Well, we can take it as direct and indirect. Direct repercussions are excessive pain, excessive discomfort for the patient, seeing blood or bleeding at the time of the embryo transfer. And of course, there is something called as retained embryo. So when we load an embryo, if we are planning for more than one or even a single embryo transfer, and if after doing the transfer, when we do the catheter check, if we find that the embryo has come back, so that's called as retained embryo. All these can happen as a direct consequence of a difficult embryo transfer. But the indirect and the most difficult outcome of a difficult embryo transfer is a negative IVF result. So it's very, very important that we should avoid difficult embryo transfer at any cost. How can we avoid a difficult embryo transfer? There are several ways. One, anticipating the problem. That is, if in the ultrasound or while doing the ultrasound we see that the uterus is curved, very retroverted or acutely anteverted, or the position is not being corrected by a full bladder, in such situations we should anticipate that there can be a difficulty. In conditions where there are uterine anomalies, for example bicornate uterus, or if the lady has two cervices, so even in anomalies of the uterus it can be difficult. If there has been history of difficulty in the past, so the patient has undergone an IVF in the past and you know that the transfer was difficult, or if they had used something called as a stiff catheter to go ahead with embryo transfer, or has had a retained embryo when they did the embryo transfer, all these we can find in the reports of previous IVF. So if there has been a difficulty, so anticipate a difficulty this time. Or if there have been difficulties during hysteroscopy or a dilatation and curettage, wherein the patient comes up with the history that during DNC they did a perforation or they found it difficult to get into the uterine cavity. These kind of situations we can anticipate a difficulty. There are also conditions like a cervical fibroid, a lump in the fibroid, a lump in the cervix, that is the mouth of the uterus, or if there has been a spur within the cervix. So if the uterocervical canal, for example, if I have to describe the uterus has two parts. This part of the uterus is called as the cervix, and this is the body of the uterus. Now the whole length of this canal is what we are hoping should be smooth and easy. Well, once anticipated, how can we prevent a difficult embryo transfer? Well, it is always prudent, a necessary step, that if a difficulty is anticipated, one should consider something called as mock embryo transfer. Now, what is mock embryo transfer? It is a transfer wherein we mimic the embryo transfer, but this whole exercise is only to know if the uterocervical length is easily negotiable. So mock embryo transfer helps us assess if the uterocervical length is easily negotiable, and with the minimum trauma to any part of the uterus or the cervix, we are able to enter into the uterine cavity. If mock embryo transfer goes easily, then we should consider that the actual embryo transfer also will be easy. But of course there are exceptions. There are times when mock embryo transfer was very easy, but the actual transfer ended up being difficult. There are times wherein one does a mock embryo transfer, finds it difficult to enter into the canal, marks all the path, but then the actual transfer becomes very easy. So all these factors to be kept in mind, but however, mock embryo transfer will give us some idea as to how the canal can be navigated. Now what we need to understand is, during embryo transfer we are using very soft catheters, and these catheters are very pliable. That means if you push it too much, they bend. When we are using soft embryo catheters, it's very, very important that there is no obstruction anywhere throughout the uterocervical canal. However, if during mock embryo transfer we find that soft catheters are not going inside the uterine cavity easily. The options are to see and use stiff catheters, wherein you may navigate the cervical canal, that is the lower part of the uterus, with a stiff cannula, and then pass the softer inner catheter to deposit the embryos. So one of the techniques to avoid or minimize difficult embryo transfer is something called as afterload technique. There are two ways of doing an embryo transfer: afterload technique and a preload technique. See, embryo transfer catheters always have an outer cannula or the outer catheter and an inner catheter that goes into the endocervical canal. The cervix has two parts: the external os, which is at the inside the vagina, and an internal os that actually opens up into the uterus. So outer catheter is a catheter that is passed through the cervix up to the internal os, and the inner catheter then passes through the outer catheter to reach the desired place. Now, doing a preload technique means you load the embryos in the inner catheter, you hold the outer catheter outside of the inner catheter, you bring both together, you pull out the inner catheter and pass the outer catheter first and then the inner catheter and finish the transfer. That is preload technique, wherein you have already loaded the embryos before you put in any catheters. Whereas afterload technique is wherein you're passing the outer catheter first, making sure that you're entering into the cervix and reaching the internal os, and then you load the embryos and bring in and pass into the uterine cavity. So afterload technique is one of the important techniques which can help minimize difficult embryo transfer, because here you're passing the outer catheter already, you know that you have entered into the lower uterine cavity, and then you pass the inner catheter to place the embryos. The other way of handling it would be to consider something called as cervical dilatation. So prior to the actual embryo transfer, either during the initial or the earlier part of the menstrual cycle or in the previous cycle, one can consider something called as a cervical dilatation, wherein we can pass a metal dilator into the cervix, dilate it at least to a number 6 or number 7 Egas dilator, and then keep it dilated so that you can have a easier transfer at the time of the embryo transfer. Now, the other way, suppose even dilatation was very difficult, in such situation one can also consider something called as a hysteroscopy, wherein you put a camera into the cervical canal, into the uterus, see if there are any obstructions. If you find that there are cervical spurs or a cervical fibroid or anything obstructing the cervical canal, you can take care of it in hysteroscopy before going ahead with the actual embryo transfer. So it is extremely important. Embryo transfer is the most vital procedure for achieving a successful pregnancy, and also difficult embryo transfer sometimes can lead in placement of embryos very low in the uterine cavity or very high in the uterine cavity, leading to displacement of embryos, either resulting in lack of pregnancy or ectopic pregnancies. To avoid all these parameters, doing a mock embryo transfer, 1, using a stiff catheter, 2, and also taking care of any cervical lesions in the previous menstrual cycle will help making sure that the embryo transfer is much smoother in the actual cycle. Difficult embryo transfer reduces the pregnancy rates in the tune of 10 to 15%, and considering that embryo transfers with excellent embryos and in good prognosis patients almost have a 60 to 65% pregnancy rate, reducing it to 50-55% pregnancy can actually be very disappointing both to the patient and the service provider or the doctor and to the whole team. So avoiding difficult embryo transfer is something that should be carefully planned, and one of the methodologies can also be a 3D ultrasound prior to planning the transfer. And if there has been a history, then 3D ultrasound is one of the new gadgets that can help us map the whole endocervical canal, which can help navigate going through the cervix easily and achieve the best pregnancy rate that's possible. Though difficult embryo transfer is uncommon, but it should be avoided at all costs, and with advanced technology like 3D ultrasound, with preventive strategies like mock embryo transfer, and with good operator expertise, one can anticipate to avoid difficult embryo transfer entirely and make sure that the chances of pregnancy are optimal for the patient.